Good afternoon, everyone. My name is Dr. Raquel Romero, and I'm going to be the facilitator for the ECHO session today. And I hope you and your family are doing well. And thank you for making the time to join the Comunidad Long COVID ECHO series. This project is a comprehensive long COVID care for underserved communities. This is an innovative delivery and dissemination project, and also known as a Comunidad. At the UT Health San Antonio, our post-COVID-19 recovery clinic serves San Antonio in a broad and large region in rural and in South Texas. And this community faces significant health disparities and barriers to care, and the misinformation about COVID and the long COVID remains widespread. To address those challenges, the Comunidad project, a 5 years initiative funded by the Agency for Healthcare Research and Quality and the Comunidad Long COVID ECHO, seeks to improve and expand the long COVID care through innovative and sustainable models in the region and beyond. If you are new to the ECHO sessions, ECHO stands for Extension for Community Health Outcomes, and it serves as a virtual telementoring, especially designed to create connections between the communities and subject matter experts. So each session we start with the introduction, then followed by a brief didactic case presentation and discussion. So I invite you to be part of that discussion during the session today. And during the case discussion, members of our community will present the real-life patient cases to address their health care needs. Therefore, to ensure privacy, no personal health information is allowed to be disclosed at any point in this session. So kindly, I would like to ask you if you please put in the chat your name, affiliation, and email. This is to help us with our attendance records. If you have a connection issue, you can always send a text or a message to the ECHO that is going to help us on the session today. Thank you so much. So with that, I would like to move with the introduction of our team, and I would like to start with Dr. Sabat. If you please introduce yourself.
Yeah, I was just typing my name in the chat.
Thank you.
So I'm Joel Savat. I'm a general internist and director of the Reach Center, and I'm one of the multi-PIs along with Dr. Verduzco Gutierrez and Dr. Kilpla on this AHRQ grant, which is funding this ECHO. Glad to have you.
Thank you very much, Dr. Sabat. And Dr. Monica Verduzco Gutierrez.
Yes, hi, Monica Verduzco Gutierrez. I am a physical medicine and rehabilitation physician, one of the PIs on our long COVID project.
Thank you very much. And normally in those sessions, Dr. Verduzco and Dr. Sabat are the lead specialists in this session. Thank you very much. And Dr. Ashley Sanchez, the didactics presenter today. Thank you so much for preparing that presentation for us. Would you please introduce yourself? Thank you. Would you please introduce yourself, Dr. Sanchez? Thank you.
Yes, good morning, everyone. My name is Dr. Sanchez. I am one of the other rehab or physiatrist general outpatient providers here who was working in the long COVID clinic for over a year and a half and have a lot of experience of going through this disability documentation that I'll be talking about. So I think I just shared my screen.
Thank you very much. And I would like to just mention that we have a case that's going to be presented for one of our clinics, and just waiting for Dr. Garza and Dr. Tamero to join. But thank you so much. And with that, I just want to say that, yeah, ECHO is all learned in all teach environment. So this is just paid, Dr. Sanchez, for the didactics. Thank you so much.
Okay, perfect. We're going to get started.
Yes, thank you so much.
All right. So good morning or good afternoon, everyone. Thanks for joining. Let's see if I can move some of these over. All right, perfect. So today I'll be talking about disability documentation and assessing for functional impairments in our long COVID patients. And it's something that's super relevant and is very tricky sometimes to navigate. So hopefully this will kind of help you guys feel a little bit more comfortable navigating some of the chaos that comes with this. Okay. So here are my learning objectives, but we'll kind of get straight into it. Hopefully by now you guys are pretty familiar with what long COVID is, but just in case anybody isn't, it's essentially when patients have persistent or lingering symptoms for at least 3 months after their initial COVID infection, and that there's no other potential cause that would explain these symptoms. I feel like more and more studies are just showing this is more prominent as we're getting better at actually diagnosing it. And I think the other thing that's really tricky with long COVID is that, even patients who were asymptomatic, who might have not been tested, who didn't know that they had the disease, can still develop some of these long COVID complications. And that over time, the symptoms can definitely fluctuate, which also makes it very tricky. So in terms of the most common symptoms that patients seem to report, also kind of mimic the kind of symptoms that they endorse that limits them from returning to their work or their activities, every day. So I think that's also important to note. And so fatigue probably being the definite most common, followed by malaise or generally feeling unwell, along with the brain fog. What differentiates COVID from like other common illnesses is that these symptoms tend to fluctuate and get worse, especially with any sort of physical or cognitive exertion, which I'll kind of explain and go into a little bit later. But that's one of the key features that'll kind of help you differentiate from other causes. And then this here is just kind of showing a validation tool for symptom scoring. As we know, a lot of the symptoms that our COVID patients report overlap with a lot of other chronic illnesses. And sometimes it's hard to pick out, do we really think this is long COVID, or is this low thyroid? Is this some sort of malignancy? And so this is based off of the Recover Long COVID Research Index. And so essentially, depending on the symptoms they report, they kind of get their individual score per symptom. And if you add them up and they equal at least 12 points, that's highly suggestive of long COVID. And kind of why I bring this up, because documenting their symptoms over time is super important for the future disability application. So you always want to make sure they have a clear timeline of what symptoms they're having, when did it start, and how has it changed over time, because that'll help you in the future when you're documenting these things. Now, completing this paperwork is really, really important and something that we can actually help a lot of our patients out for, because of course we understand, as we do not have a specific long COVID treatment or cure at this time, the most important thing that we can do is give them enough time to recover and to adapt to maybe their new level of function prior to rushing them to go straight back to work. Because of course we know that rest is really important to improving their overall quality of life and improving their recovery. Of course, we also see too that relapses of long COVID syndrome are super common. And so it's really important that we educate our patients that this is a potential possibility out there, almost so they can be better prepared of what to do. And so there are kind of various things that can trigger relapses. So things socially, like work deadlines, or if they're going to be up for promotion, things like that can definitely make things more difficult. Stress, whether that is at work, whether it's in the family or at home. And then, of course, physically, patients can overexacerbate themselves, whether that's going to a strong workout or even if they're sick with other things. So whether it's a repeat COVID infection or things as simple as the flu or a GI bug, all of those things can definitely trigger a flare of their COVID symptoms. So they might thought they have previously fully recovered, and they'll see a recurrence of their symptoms, and or a new symptoms can also be joining along with when they're acutely ill. And so we know that a significant amount of patients have reported that their symptoms limit their day-to-day activity significantly. So some examples of things that patients can talk about is that maybe after their illness that they are unable to return to their full workday like previously, right? That some patients even have trouble getting ready to get to work, right? They have I have patients who told me it takes them like 2 hours to get dressed because of the shortness of breath and taking all the breaks that they need to kind of slowly get themselves ready throughout the day. There's research that has shown that some patients do experience a reduced exercise tolerance, right? So that's been measured as a decrease in the peak VO2 max in about 5 milliliters per kilogram per minute. And so depending on a patient's work capacity, that could be significantly important if it's something that's very physically involved. And then, of course, a brain fog, one of the other most common symptoms, can affect patients in various ways. Some patients have difficulty finding words, difficulty multitasking, difficulty presenting, or making more complex judgments that used to be very easy for them. And now to complete the same amount of tests may take significantly more amount of time, or they might have to be asking for help, which prior to COVID, they might not have had to do any of that. And I think what makes COVID especially tricky, as I'm sure you all know, is that it is considered an invisible disability, right? People otherwise look fine. There's no physical manifestations. And so that it leads to a lot of patients being gaslit and being told that, it's not true, that they're distressed, they need to rest, and that, makes everything just much more difficult for these patients. And then in terms of the functional assessment tools, so why these are very helpful, because it kind of helps make the documentation objective. The majority of what we get is just subjective. We have no way of disproving any claims that they're saying. So this is where the validated tools can come in handy. The other thing that is really helpful is repeating them over time to kind of help track changes over time, to see how, if things are improving with treatments, or what things the patient had a recent flare, does that correlate with a recent stressor in their life? These tools are also important for helping disability claims. Is much more powerful if you have, some of this data to kind of back it up. And then it also helps everybody kind of speak the same language, right? If they see a long COVID provider in one city and then follow up their primary care in another city, hopefully if this is all documented appropriately, everybody is on the same page about what's going on. There's several different tools that you can do that kind of measure different aspects that I'll kind of go over a little bit more in the next slide. So some examples of some tools that measure their functional status, right? So their day-to-day activities. There's things like the post-COVID-19 functional status scale. There's the COVID-19 Yorkshire Rehabilitation Scale, and there's things like the functional impairment checklist. And then in terms of quantifying their symptom burden and how it's affecting different things, there's the long COVID symptom or impact tool, and then things like the fatigue severity scale. And then in terms of cognitive assessments, we could always do a MoCA. There's also neuropsych testing that can help give you more objective evidence into any sort of cognitive deficits. And then just kind of briefly go over some simple, more exercise testing that can actually be performed in clinic, and or with a physical therapist if you happen to have like a multidisciplinary clinic. There's things like the 1 minute sit to stand test, right? All it requires is a chair and a watch. You're essentially watching them do squats without using their hands and timing how many reps that they can do over time. There's that 2 minute step test, which is them essentially doing high knees and timing how many reps they can do over time. Then there's actual distance testing, like the 10-meter walk test to check their speed, the 6-minute walk test, looking at how much distance they can cover in that time. And then there's something else called the Modified Medical Research Council Dyspnea Scale, which is essentially assessing for their breathlessness. How would they rate that throughout the different activities, before activities, during activity, post activity? So all of these are examples of objective ways to document for exercise tolerance and or any sort of oxygen desaturations if you also have the pulse oximeter. Because it's like one thing for a patient to say, like, I'm tired, I can't, exercise anymore. Versus another thing to say, we expect them to do this many reps for a sit to stand for their age normal standard, and they are this much below. That provides you a lot more strength to some of the claims. Now, something else to remember too is that technically long COVID can be considered a disability under the ADA if it substantially limits one or more major life activities, right? And as you can imagine, as a multi-system illness, it can easily cause issues with multiple different activities of daily living. You just have to make sure that you kind of document how some of their symptoms are impacting certain things. So these are some examples that I have kind of listed here that I'll kind of go into a little bit more detail later. Now, in terms of what are some examples that we have written previously for workplace accommodation, specifically for our long COVID patients, I do want to emphasize that it has to be individualized and, specific to whatever different things that they are struggling with. And I think what really helps too is that for the patients to kind of tell you what areas of their essential job functions can they not do and kind of why, what symptoms are really limiting them. That helps it make it easier then to make appropriate accommodations, for those specific tasks. So something simple as having a flexible work schedule, because as we know, some of our patients tend to fluctuate of days that they're feeling better, when they're feeling worse. So if they have any sort of way to switch their schedule around to allow for them to work whenever they are feeling well, That kind of goes along with allowing remote work or telehealth options. I know some people have a big fear of returning to their prior in-place work settings where there might be a lot of people crowded and they're worried if they might get re-exposed again. And that causes a lot of disabling anxiety that can limit their ways to be effective in work. And or if they're allowed to get frequent breaks as they needed to rest or change positions to allow them right to continue to work. Sometimes we do a structured kind of gradual return to work program where we start them at maybe half the time that they were doing and seeing how they tolerate. Does it flare any other symptoms and kind of gradually increasing it as they can tolerate back to their full work capacity. So some examples of some modified duties to reduce symptom load would be to avoid prolonged standing, avoid position changes. That's more kind of like going from standing to squatting, kneeling, things like that, because that can trigger orthostasis. For some patients who struggle with the brain fog or cognitive impairments, sometimes we'll ask if their employers can give them written of any sort of deadlines or of any important communications or like notes of for the work meeting. So that way they don't necessarily, they can kind of prep beforehand. They don't have to only rely on what they remember verbally, because that sometimes can be very difficult, especially when they feel pressured. Also, we've had some patients who report that they feel like it takes them longer to learn a new skill, and it can be more difficult, more challenging. So we've asked for them to have extended time to kind of learn new tasks. There's things like making sure they have an ergonomic workspace condition, trying to limit, again, for the cognitive wise, trying to limit their tasks. They're having to do multiple things at once. That's typically where patients tend to get overwhelmed. And then trying to reduce any sort of sensory stimulations, preferably working somewhere quiet. I had a patient who was once very sensitive to smells, and I think their office was located right next to the bathroom. And so we had asked for them to be moved somewhere else so that they wouldn't have to be worried or, constantly thinking about the smell from the bathroom that could be limiting them from working efficiently. Then there's a whole bunch of different kinds of forms that patients will have you bring out of the blue that, of course, are always due the next day that they want you to fill. And so I'm going to just kind of briefly go over some of the differences for some of these, because it took me a while to kind of get a grasp of what exactly was I signing these patients up for and what does that mean in terms of how is it going to affect their pay and how much time they get off. So I feel like initially patients will be asked to submit FMLA. That usually covers patients to be off work or partial time at work for up to 3 months, and typically it is unpaid whenever they're not going in. So that gives them a set amount of time so they can focus on their recovery, right? It was essentially this is what all this set amount of time is for. Then you have short-term disability or STD. This usually lasts anywhere from 3 to 6 months and is a form of income replacement, right? Then you have long-term disability that is typically after the short-term disability ends, or typically anything longer than 6 months. And it's another form of partial income replacement. And then ultimately there's Social Security Disability Insurance, or SSDI. This is when you anticipate the patient's going to have to be out for at least a year. It's a form of income replacement, but you're essentially saying that you do not expect this patient to return to work in any sort of capacity. That they are like permanently disabled, right? That's where the SSDI comes in. And you will fill out records for all of these. Now, in terms of what can be really helpful to document in your notes, you want to make sure you get a really thorough history. When were they diagnosed with COVID? How were they treated? What symptoms began? How have the symptoms progressed over time? What makes the symptoms better or worse? How does this affect their day-to-day activities? Whether it's limited them with driving, with work, with their basic ADLs? Is it limit them socially? Then you want to try to make sure you include any sort of objective testing. So what prior lab workup have they done? Or is there any abnormalities on the chest x-ray, on the pulmonary function testing if they have any respiratory issues? Are you concerned about POTS? Have they done tilt table testing to confirm it? Have they completed any sort of specific exercise testing? Especially if their job is very physically demanding, and then if they're reporting any sort of cognitive deficits, do they have any prior MoCA scores? Have they been evaluated by neuropsychology? In terms of physical exams, sometimes vitals I feel like are really, really important. If you get orthostatics, that would be great. That's an extra bonus. We often find patients will not necessarily report anything, but then we see abnormal vitals on the orthostatics, and then we kind of like coach them through, and they're like, oh yeah, you're right. I am a little bit dizzy. Or sometimes when I stand up, I have to kind of like hold still for a little bit before I can move. making sure you get a good cardiopulmonary exam to rule out any other causes, and getting a good baseline strength and sensory exam along with a cognitive exam will kind of help your case. And then you always want to make sure you document an assessment and plan. What treatments have they tried? How have they responded? How long do you anticipate for these symptoms to persist? And are they limiting them enough that they need certain work accommodations or leave to kind of help them focus on the recovery so they can ideally go back to work full time? Now, as far as things that you want to make sure that you do include, you want to try to use, right, the validated tools, because something saying as for example, here, a patient has fatigue is very vague. It's hard to say, like, how severe is that? How is that over time? It sounds much stronger, right? If you're able to include some sort of scale that kind of shows the severity of it and how does this symptom limit different functions of their day-to-day. The key, really key, is tracking change over time. I think that'll kind of help get the buy-in to explain the severity of these symptoms. Making sure they, like we said, document any sort of prior treatments that have done and how the patients have responded, and just trying to see their overall progress over time. Do they seem to be uh, making improvements with appropriate treatments, or are things kind of just still persisting despite multiple things that you have tried? As far as common pitfalls to avoid, you want to avoid those vague descriptors. Very often patients will come to you and say, well, I can't work. And that's hard to fill out disability forms if they have not explicitly stated what exactly they can't do. So trying to draw out as much of that as you can will be very helpful for you. Lack of any sort of objective data can make it difficult. If you're missing the symptom timeline or the burden, that can also make filling out some of these paperwork very difficult, and or ignoring how COVID affects any sort of pre-existing comorbidities. You know, it's very often that COVID seems to throw prior medical conditions kind of out of whack, like things like fibromyalgia will really flare. I have patients who were previously well controlled on their diabetes or their thyroid medications, and then after they get COVID, they are all over the place with some of the other specialists that they are trying to manage some of these things that were previously well controlled. And then just in summary, as far as my key advice or takeaways, is to always make sure you recognize that COVID is technically a disability under the ADA, so that employers are responsible for providing reasonable accommodations. Try to take advantage of the validated assessment tools that you have at your disposal. At our clinic, I know we have patients fill out some of these forms before they come in, so that way we can kind of track stuff over time. Try to make sure you be as specific and objective in your documentation as you can. Don't just accept when they say they can't do something or that this symptom is bothering them. When did it start? Why? And how is it affecting their day-to-day? And then accommodations must be individualized and they may change over time, right? So you kind of have to be flexible depending on how their recovery goes. And then I think the key, especially for when applying for disability, is having the documentation over time and kind of showing like, look, they've tried all these things and we're still struggling. So this is why we're applying for disability at this time. All right, and that's about it. Thank you so much for having me.
Thank you very much, Dr. Sanchez. This is a very, very good didactic presentation. I really been learning a lot on this. Thank you so much. Is there any question from our audience to Dr. Sanchez? I do have a question. You mentioned several assessments, tool assessments, and I thought it was very, very interesting. If, let's see, a practice, a clinic don't have a multidisciplinary team approach, what tool assessment can be recommended at the primary care physician?
Yeah, so sometimes we'll send them to the physical therapy, right? There's things that you could do like that functional capacity evaluation or the FCE, or especially if this work usually comes often if they're workers' comp, but I think it could be helpful even when they're not workers' comp, especially if a patient has the physically demanding job, right? So kind of seeing if there's any sort of way to get any objective limitations, right, of their physical capacity, I think can help you with filling out any of these forms. And then that's where we also really use the neuropsych evals too, because the brain fog is probably one of the most common symptoms.
It's very common.
Hard to say, like, are they just not sleeping well, right? Is there stress going on, or do they have some sort of objective cognitive impairment? And that's where the neuropsych testing can really help tease that out They also provide some great recommendations in the neuropsych testing as well, that can either help when sending them to speech therapy or just things to pass along to the patient of different strategies they can use to help overcome some of their limitations that they may have.
Mm-hmm. Yeah, thank you very much. And Dr. Sabat?
Yeah, just that was great. Thanks. Just a couple practical questions. Who in your clinic actually fills these out when they hand them to you? Do you do it, or do you hand it to a nurse practitioner or some other staff member? And then how often are these returned for more information?
Yes, so two great questions. So typically when we are initially getting done, typically I'll have one of the physicians or the nurse practitioners try to take a look at it and fill it as much as they can. Um, and then when it's like a repeat person, like they're still having the same issues, and we're not really changing anything, then typically our nurses will have we'll have them fill it out, and then we just kind of quickly sign off. Because you can imagine becomes a lot, very overwhelming for kind of one person to be doing, especially when you're caring for so many patients who all have these similar needs. And then in terms of how often do we get them back asking for more information, I wouldn't say that's too often. Um, I would say workers' comp is probably the one that'll give you the most, like, they'll want more information if you don't have it already listed. But I would say other than that, I haven't gotten too much pushback or asking for more clarification, um, in my experience.
Thank you very much. Please bring all your questions. You can articulate that by unmute yourself. We also would like to see the faces, the video, if you can show on the video. I'm gonna ask this question. We have a case to present, and I wonder if in the audience, maybe it was logging into different name, is Dr. Garza or Dr. Camero in the call right now in the session? I don't see the name, but if I'm not reading this correctly, please correct me. And if you're logging in under another name, would you please let us know? Because I know we have a case for this session, but maybe they have a long morning clinic and they haven't been joined the session yet. While we're waiting, do you have another question, another comment? Something about long COVID that we would like to learn while we're waiting for this case to be presented?
Do you want one of us to read the case in case they're unable to join, or what would
Yeah,
you?
yeah, maybe we can do that, Dr. Sabat. Maybe if you can have the case and if you can, I mean, yes. Yes, Dr. Sabat, yes.
Is there a way to enlarge that? Hold on. Okay. Yeah, I'm happy to do it. I don't know the patient myself, but we have some information here. So this patient's an 18-year-old woman who was previously healthy and had COVID in January 2021. She had many complications, including myocarditis, resulting in biventricular heart failure and multi-organ system dysfunction requiring ECMO. She also had a blood clot in her right leg and required an above-knee amputation. She was then readmitted in cardiogenic shock from influenza myocarditis, and again required ECMO. That was in February 2025. She has also had a history of TIAs along with minor strokes and an embolization in the left renal artery in January 2023, managed with anticoagulants. She then got pregnant, recently got pregnant, is currently being followed by the Texas Children's Hospital for her pregnancy. And she's also followed there for post-COVID complications, including her heart failure. So she's 19 years old.
Yes, he's 19 years old now.
Okay. And we don't know much about the number of COVID infections or her vaccination status. Her long COVID symptoms are listed there: cardiovascular, neurologic, and vascular complications. She had developed new medical conditions after COVID, as described above. Her meds are enoxaparin and hydrocortisone. And so they submitted a series of questions for us to discuss as a group. When we first received this case, I was wondering, is this kind of strictly a clinical case, or is it also a health systems case? In other words, is there a problem? Is this patient having a problem, or are the providers having a problem dealing with the health system itself? As it turns out, so one of the issues from a health systems case, I suppose, is that she wasn't able to get the high risk or the maternal fetal medicine care, I think, locally, and so is driving to Houston for care. So that's and I think that's not uncommon for patients with with the more severe complications. What exams need to be done to avoid complications? I'm not sure what that question is directed at exactly, other than maybe during pregnancy.
Yeah, Dr. Verduzco, I see your hand.
Or can I start answering questions?
Sure, please do.
Okay.
Yes. Thank you.
So just a little bit of background about what happens with pregnancy. So pregnancy, is like I would say is relatively your immune system in women, actually, you're not totally immune compromised, but your immune system calms itself because you don't want to attack this foreign little baby that you have. But therefore, it can be an independent risk factor to have more severe COVID-19 as an acute infection. So if we're thinking not just long COVID, but saying like this is a person, we usually have summer spikes. COVID's going to be around in the community before we know it. Maternal risks, if they get COVID, they can have more ICU admissions, a lot more preeclampsia and eclampsia, if you think about, the endovascular effects, clots, even like increased risk of maternal mortality. And then also for the baby, a lot higher risk of preterm births as well. And even unfortunately stillbirths that you hear about with being infected with COVID-19. And then there's some actually morbidity with the baby being also increased of neurodevelopmental issues and neurodevelopmental delays in babies who were born to women who had COVID during pregnancy. So first, I would often, I would still encourage vaccination. I would encourage, mom being safe during high peak COVID times, wearing masks in crowded areas, those types of things. The other thing is like, it's kind of if she's traveling for care and we know that she's going to be at risk of, maybe having preeclampsia or something, is there a way to make sure that she's going to have access maybe to another center that's nearby to where she lives in case of an emergency type of thing? If now we're just talking about, so what exams need to be done to avoid complications? I am not an OB/GYN, so I don't know, but I'm sure they have ways that they can monitor them most closely. Also have the patient again, monitoring their blood pressure and their symptoms at home as well. So those are my first kind of answers.
Can I jump in you mentioned COVID-19 vaccination?
Yeah.
As you know, the CDC has kind of softened their recommendation about that in terms of making it more an individual decision-making or shared decision-making, but the leading OB/GYN society still strongly recommend it.
Right.
And so yeah, this is very, very important for the clinic to be informed about this. And so maybe, is that okay if we can move to the question number 3? How can external clinical partners support local clinics in providing patient care?
Yeah,
This clinic is a rural clinic. It's about, I would say, close to an hour driving to San Antonio. They may they have a room that they can have like an internet access. As we know, in rural areas may have internet situations, internet problems. So they offer this, and so how we could some way personal or by video visits, we can provide some support to these rural primary care clinics. I think this is the question. Yes. And I'm not sure if we can.
yeah, I think this is a challenge in general,
Right.
but because this patient has multiple complications and sees multiple providers, we happen to see her upcoming appointment list. And she had at least, I don't know, a half a dozen appointments with different specialists
Mhm.
coming up. And, that's a challenge in any healthcare system. Who's coordinating the care? How much information are they being provided from the other providers? Are they all on the same page? Are they all, and then when you add in, okay, now she's going to Houston.
Mhm.
So that's clearly a challenge here. And under ideal circumstances, I suppose the primary care provider would be able to coordinate all this, but that doesn't always happen.
Yeah, the coordination of care is going to be also very challenging, and perhaps maintaining the primary care visits. I know they maintain the appointments with a primary care doctor. It will also be helping them, right, in the coordination. But yeah, reportings and
Let me, if you don't mind, I see Martha Castillo on the call. From your standpoint, how could one coordinate this care or help the patient navigate the system, or what do you think?
I think that we need to educate them on what exists that can focus on this, but it's giving them good information, and also see how we can address the barriers, which is we sometimes with transportation we have several people coming or scheduling on the same day to come and share the ride. If there's grants that provide incentives, money for the Uber or something like that, we use that too. I'm sorry, is that the answer you're
Oh, no, whatever. I just, I'm guessing you encounter this situation in your region, and just helping the patient figure out kind of what needs to be done and how to do it best, right?
Yes, and it's usually the community, other community members that help with this. That's what we've found. And sometimes it's a family member that will address the issue with transportation, but a lot of community members are out there working too, so it's very difficult to do that when the clinics are closed, when the other individual can help. And some of us, some of the promotoras that are not employed, that are volunteers, they'll take them. They'll do it because those of us that are employed, sometimes we can't do that. So the ones that aren't employed or that are working part-time or at a place where they won't get in trouble, there's the one they take it, and the rest of us provide money for gas.
Basically, voluntary work, right, Martha? It's like it's right, because if you are not in an organization, it's basically voluntary work. And indeed, a lot of promoters, this is what I do, right? But yes, what kind of resources do you think it will prove the education to that person? Like how we can educate a person in this situation, in
Well,
your experience?
we do community, we bring in speakers, or if we ask them to train us on how to educate the people, but it doesn't necessarily mean that it's going to go to a clinic. We do it at some community centers too.
Mm-hmm.
That's where, if it's close, if there's a community center close to them, we'll
Mhm.
ask several of the families or family members to come. And that's where we do most of our work, in community centers, churches, nonprofits, that will allow us to do that, because not many do. They all want us to be a nonprofit, or they want us to have insurance. But I've worked long enough in this that I've developed relationships where they help me, and most of them because I've worked in those places. So I've been navigating everything and building relationships. But I have a relationship with the school district that can lend us some space, because I'm on their board. Um, a community center that has a big space for a senior center, and a church that has the sanctuary that's utilized for that, for education. So it's about building partnerships and being able to get the patients involved, to educate them, and then navigate, and then help them get into the treatment.
Mm-hmm. Yeah, so helping the patients in any capacity possible, right?
Mhm.
Thank you very much.
Thank you. And we've also done home visits.
Nice.
Mm-hmm.
Thank you.
Thank you.
Thank you. So we have Dr. Monica Verduzco, is there another resources that we have available to improve education
Yeah.
in patients and perhaps in clinics to prevent situations like this, or hospital, because she also, I think, went to the hospital, the regional hospital. Yeah, in your experience.
So definitely, support groups. So if a patient would reach out and look for support groups, there's a lot of information online on that. And the other thing is that the NIH Recover has a large trial on COVID and looking and following long COVID. And they especially did treatments with pregnant persons, or like not treatments, but research on pregnant persons. So in their website, they have the research that they've looked at into what are the outcomes when someone either has COVID during pregnancy, or the other way around, like had long COVID and became pregnant.
Mm-hmm.
Yeah.
And that was very good information to provide to the clinic so they can contact the
Yeah.
patient if they are interested in doing that. Is there another recommendation in this particular case? Because she's very young, she's 18 years old, is staying in this situation, right? What else we can tell the providers and how they can help the patient? Dr. Sabat, Dr.
In terms of her pregnancy, or in terms of her,
Yeah, I think one of the concerns right now is 18 years old and is having, unfortunately, they have a complication of this amputation, and now she is pregnant. She needs to go to Houston. So how we can offer other resources for them to offer the patient?
So I'll give kind of an overview of if a patient that has had like multiple complications and has had issues from COVID and maybe has like long COVID, because when we did our consensus guidance statements, I was actively involved in the part that looked at health equity. And so what happens when a pregnant person again has long COVID, how do they present differently, those types of things. So first, it's interesting because they're like, pregnant women are tired and long COVID people are tired. If you've been pregnant, you know what that fatigue is. If you've had long COVID, so really you still need to do, the pacing based rehabilitation, energy conservation strategies for these people as well. So telling them how to pace themselves, how to kind of, prevent crashes, you don't want them to do the traditional like progressive exercise programs. The other thing is if they need type of, fatigue, or if they're really fatigued, or if they need rehab programs for, problems they may have or pains they may get that can be increased in someone who has long COVID or be already high to start with, then you have to know like their body changing is going to change their center of gravity. There might be an increased risk for falls, those types of things. So sometimes you have to do different types of rehabilitation for persons who are pregnant so they don't kind of worsen their symptoms. And really, again, focusing on the pacing for them. The other things that sometimes these people have is brain fog. Well, also, we think like we have mommy brain, we have pregnancy brain, those kinds of things. But so these patients may need to go to also do, speech therapy that can give them cognitive strategies, or do they need to be pacing for what they do for, cognitive issues? And then also looking at psychological symptoms, because we know that hormones and pregnancy and already inflammation with having COVID and long COVID can cause psychological symptoms. So making sure that there's a psychologist involved if need be, that the person get cognitive behavioral therapy if that what they need. Yeah, so that has some evidence for helping in long COVID. Breathing, like it's a hard time to breathe. It's been a long time since I've been pregnant, but you definitely get shorter of breath faster than you would otherwise. And so, breathing exercises are safe. Physiotherapy where you work on breathing is safe and recommended for them. If they are have problems with sleep, which can also happen as you get like progressively more uncomfortable. You can do cognitive behavioral therapy interventions for sleep as well. Definitely, sleep hygiene is a very important thing during pregnancy. So you're not just like adding medications. Again, monitoring their blood pressure, monitoring blood glucose, because again, COVID can increase risk for people to get diabetes, and these patients do get more gestational diabetes. So monitoring for both, elevated blood pressure, preeclampsia, eclampsia, and for glucose screening, maybe even an early glucose tolerance test for a patient like this. And then there was something about a clot, or she was on Xarelto or something beforehand.
Yeah, it was the
Additional
context.
comments related to the patient.
Yeah, she got let me get this here. She got a vascular complications where she got a clot and then she got an amputation. So she was on that medication.
She's still on Xarelto because she probably shouldn't be.
Let me see if it's in the list. It's
No,
not
she's
in
on
the
a
list.
Noxaparin now.
Okay.
It's not in the list right
Oh,
now.
okay. The Noxaparin. Okay.
Yeah.
All right.
But just also when someone is on, thromboprophylaxis, then I know there's sometimes they deliver early, or, it's scheduled. Maybe their delivery needs to be early and needs to be scheduled and induced. And that way you don't wait till there's an emergency and she can't travel to where she needs to travel.
Correct.
Yeah.
And so giving the recommendation to go to that and contact the doctor as soon as possible so she can prevent complications. Thank you so much, Dr. Verduzco. Give us a very good healthy behaviors that we need to consider in this case. It's important for everybody, but in this case, particularly very important what you mentioned, the pregnancy, the blood pressure, the glucose, and sleeping, breathing, all this very, very important. Dr. Sabat, you would like to include in this list something particular for this case?
Sure. So first of all, thanks again to Dr. Sanchez and to the clinic for presenting this case to us. And you think about it, she was like 14 when she got COVID. And she's had multiple complications that we wouldn't necessarily expect in a young person. So this was a really severe case. now it's just 5 years ago, she's still dealing with all these complications. And on top of that, a pregnancy, as we discussed. So, and the issue of, having to travel all over the place for her care. So I think it's a good example of both some of the clinical and health system issues that one can see with long COVID.
Yes, thank you so much for all these recommendations. I want to make sure that Dr. Garza and Dr. Camero receive those. A very interesting case, and we may ask for follow-up of this case. They've been facing a lot of barriers, and maybe there's some facilitation for the care. And thank you all to be part of the session today. You can earn some education credits, and the information is in the chat. And please keep checking your emails as some more sessions are coming. We don't know exactly when. Perhaps it's going to be after summer when I have another series of sessions for this long COVID. But I invite you to think in a case that you may see in your community and you would like to present here. And we can, among all the team, we can try to think how is going to be the best way that you can continue taking care of your community. I know, and we know that this is very important for everybody. But thank you so much for being part of this session, this learning opportunity, and I hope you have a wonderful rest of the day. Thank you so much. Thank you, Dr.
Thank you.
Monica Cadusco, Dr. Sabat. Marta, and everybody else.